Now we move on to the final lecture for the day. The topic of the lecture will be, what should a urologist know about familial urological cancers? Over to our moderators to introduce the revered speaker.
It's going to be the last plenary of the day's proceeding. It's a pleasure to invite Mr. Steve Garnett. He's a consultant urologist from Eastbourne, United Kingdom, to deliver his talk on what should a urologist know about familial urological cancers. Over to you, sir.
Thank you. Thank you, everyone. Thank you for the kind invite. I was last here 30 years ago for my medical student elective, so it's great to be back. Last talk of the day, so I'll try not to take too long and we'll move on. So, familial urological cancers. What I want to briefly cover is what they are, why they're important, where they occur, and when or who to test. I'm not going to be able to cover everything in this short time period, but we'll focus on some of the more important syndromes. So what is familial cancer? That's a cancer, the same cancer occurring in two or more genetically related individuals. And a subset of that is called hereditary cancer, which is a high-risk familial cancer for which the predisposing genes have been identified. And it's characterized by a high predisposition to develop tumors, usually at a young age, and it's generally an autosomal dominant disease characterized by familial clustering of these early onset cancers. Why is it important? Why is it something that's always in the textbooks and we always have to learn about for exams? Well, it's important because the investigations of these clustered groups of cancers have led to understandings and developments in the genetic basis of the far more common sporadic cancers. So they provide a clue and a starting point for narrowing down the genetic basis of sporadic cancers. And also because screening and early detection of asymptomatic cancers in these at-risk populations enables better management and better outcomes for these patients. And again, also because we know, if we know that there's a hereditary cancer, that might alter the treatment strategy given to these patients. So, for example, we saw a von Hippel-Lindau case earlier in the MDT discussion. In those cases, not in that particular one, but if that had been picked up early with smaller tumors, there'd be a greater emphasis on surveillance rather than treatment in early stage. And these type of hereditary cancers are about 5 to 10% of all cancer diagnoses. A lot of what we know about hereditary cancer has come from the Swedish Family Cancer Database, which is an extensive database with very good and uncorrupted data, which has been allied to population databases in Sweden. And this has allowed calculation of familial relative risk for various cancers. So if we look at prostate, we know a proband is a first-degree relative, so the standardized incidence ratio for someone with a first-degree relative for prostate cancer is an increased risk of about twofold. And we know that it's much greater if there's two first-degree relatives. And if we look at kidney cancer, that's even greater. And the slide shows the familial cancer proportion. That's the proportion of cancers, for example, prostate cancers who are found to have a familial component. So for prostate cancer, it's very high, but that's probably related to the fact that prostate cancer is very common. This slide shows a number of the genes that have been identified as being related to particular cancers in those specific organs. I'm going to talk a little bit now more about kidney cancers in particular because these are better sort of defined and more common. This slide is not going to be easy to read, but it's really there to just illustrate the fact that there have been quite a few different syndromes with different genetic bases identified for kidney cancer. Obviously, the ones that we're most familiar with will be von Hippel-Lindau, tuberous sclerosis, and hereditary leiomyomatosis kidney cancer. So let's talk a little bit about von Hippel-Lindau. This is the first described and most common hereditary renal cancer syndrome, with an incidence of just under 1 in 40,000 births. As I said earlier, this is particularly important because it was work led from investigating von Hippel-Lindau syndrome that identified the nature of the genetic abnormality in sporadic renal cell carcinoma. So it's an autosomal dominant disorder due to germline mutations in the von Hippel-Lindau gene, which is a tumor suppressor gene on the short arm of chromosome 3. These patients are at risk, as we saw earlier, of multifocal clear cell renal cell carcinoma, pancreatic cysts, neuroendocrine tumors, particularly of the pancreas, pheochromocytoma, retinal angiomas, and CNS hemangioblastomas. About 2/3 of these patients present with kidney lesions, either multiple cysts and or renal cell carcinoma, and there can be several hundred in the kidneys. The lifetime risk for these patients of renal cell carcinoma is very high, up to nearly 50%. There is a low life expectancy, and renal cell carcinoma is the leading cause of death. There's a very high penetrance of 70%, and that means that patients are very likely to develop these abnormalities. So if you've got von Hippel-Lindau, or if you have a genetic disorder with a high penetrance, that means you're very likely to go on and develop the cancer abnormality. So von Hippel-Lindau is classified into type 1 and type 2, basically on the presence of pheochromocytoma. Most patients with type 1 don't have pheochromocytoma but do have RCC, whereas type 2 do have pheochromocytoma. Moving on, other hereditary cancer syndromes in the kidney, hereditary leiomyomatosis and RCC. So this is a syndrome characterized by the presence of cutaneous and uterine leiomyomas. About 1/3 of these patients have renal tumors. You may have seen the sort of facial leiomyomas as sort of whitish follicular lesions around the nose and face. So this syndrome has less penetrance, but the renal tumors are usually aggressive. It's due to a germline mutation of the fumarate hydratase gene, which is a Krebs cycle enzyme, codes for a protein in the Krebs cycle, which leads to a pseudo-hypoxic pathway, which is thought to be similar to the VHL mechanism. Another one that will be familiar to you for studying for exams is Birt-Hogg-Dubé syndrome, which is a rare autosomal dominant dermatosis due to mutations in folliculin codifying gene, FLCN, which is on chromosome 17 and appears to regulate the mTOR pathway. This also leads to skin lesions, pulmonary cysts, spontaneous pneumothorax, and bilateral multifocal kidney cancers. And there are a number of different histological types of kidney cancer with this, including hybrid tumors. Tuberous sclerosis is an autosomal dominant syndrome affecting about 1 in 6,000 births with multifocal renal tumors. As we know, cognitive development problems, seizures, developments of hamartomas in multiple organs. Nearly 60% will have renal lesions. The vast majority of these will be angiomyolipomas and or cysts, but there are a small number of clear cell renal cell carcinomas in these patients. And the differences seem to be due more to where the germline mutation is, whether it's TSC1 or 2 gene, and TSC2 leads to more severe problems. Moving down from the kidney to the upper urinary tract, urothelial carcinomas. Many of you will be familiar with Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. So this is a germline mutation in mismatch repair genes, high penetrance with familial clustering of colorectal cancers in particular, but extracolonic sites include endometrial, ovarian, urothelial, gastric, small bowel, pancreatic, hepatobiliary, brain, and sebaceous tumors. So most commonly colonic, but then endometrial and urothelial is the third most common. And these patients too have a significant lifetime risk of upper urinary tract tumors. So again, depending on the type of germline mutation affects the risk of developing a urinary tract tumor, and it's sevenfold more common in those with an MSH2 mutation. In these patients, there's a lack of the typical male predominance of TCC, and the tumors tend to be more ureteric than renal pelvis. So you should suspect this in patients aged less than 60 with a personal history of a Lynch syndrome cancer, such as a urothelial tumor, a first-degree relative less than the age of 50 with such cancer, or 2 first-degree relatives with those cancers. Prostate cancer is a more complex situation when it comes to the genetic understanding. It seems to be a polygenetic inheritance. As I've said earlier, 1 first-degree relative doubles the risk, and we know that if you have an affected brother, that's a greater risk than having an affected father. And the most common or the most important genes identified are really the BRCA genes and some of these DNA damage repair genes and DNA mismatch genes, such as HOXB13 and CHEK2 genes. So given that it is more complex in prostate cancer, how does that affect our screening? We know that screening for prostate cancer is controversial anyway, given the limitations of the current screening tests, but the IMPACT study looked at PSA screening in BRCA patients and mismatch repair gene germline mutations, and they came out supporting annual PSA screening in younger men with BRCA2 in particular. So the most prevalent and strongest association is with BRCA2, and these patients tend to have more aggressive cancers. So if there's a family history of BRCA-related hereditary cancers, such as breast, ovarian, pancreatic, then screening is suggested from age 45, but if it's BRCA2 identified, then screening from age 40. So in conclusion, the early recognition of hereditary urological cancers may influence diagnostic, screening, and therapeutic decision-making and affect outcomes for both patients and family members. There's growing affordability now and speed of genetic testing, plus the escalating demand, so we may have to consider whether, certainly in the UK, whether our genetic counselling services are able to cope, and whether we may need to think about genetic testing after consultation with the urologist rather than the typical referral for counselling. And with kidney cancers, due to the multifocality, we would recommend active surveillance until tumours reach 3 centimetres and nephron-sparing surgery where possible. So as a final slide, just showing when germline testing is advised. Well, I thought I'd timed it quite well, but not quite. So anyway, there we go. Thank you. That's it.
Now, so I would like to invite Dr. M. Taha to present the token of appreciation to Mr. Steve Garnett.